Hello, everyone, and welcome to the May issue of DermSurgery Digest. I am Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. This month, we are continuing with our updated format, which will separate the cosmetic portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Rapid Pearls, will briefly cover the clinical application of the data from each article not covered in our Spotlight episode. Our goal with this format change is to make the content more digestible with a focus on clinical application and enhancing patient care. Our feature editors for May are Payvand Kamrani with Aesthetic Solutions, who will be providing the article summaries, and Terrence Keaney with Skin DC, who will offer expert commentary. Thank you for listening. We hope you enjoy this new format, and as always, have a happy surgery day.
Welcome to the DermSurgery Digest Rapid Pearls episode. My name is Dr. Pay Kamrani. I'm a dermatologist practicing in North Carolina, and this month's featured expert is Dr. Terrence Keaney. Dr. Keaney, would you please introduce yourself?
Hello, everyone. I'm Dr. Terrence Keaney, board-certified dermatologist in the greater DC area, where I founded Skin DC, a private practice in Arlington, Virginia.
Wonderful. So this episode is going to feature some quick article summaries and some rapid pearls from the remaining articles of the May 2026 Dermatologic Surgery. So the first article, The Role of the JAK-STAT Pathway in the Pathogenesis and Treatment of Keloids, a systematic review by Margaret Kabakova and Jared Senior Author Agado. This is a PRISMA systematic review of the JAK-STAT pathway in keloids that included 23 studies, 1 clinical trial, and 22 basic science. The headline clinical study was an open-label trial of oral tafostamab, JAK1 and 3 inhibitor at 5 milligrams twice a day for 12 weeks in 7 patients, which produced significant reductions in scar assessment scores, thickness, pruritus, and pain with only 1 withdrawal for mild liver abnormality. Preclinical data consistently showed that JAK2 and STAT3 inhibition reduced fibroblast proliferation and collagen deposition. STAT6 involvement raised a parallel with dupilumab, already showing anecdotal benefit. Systematic JAK inhibitor safety remains a major hurdle with the hope of a localized formulation in the future. Any pearls to share with us, Dr. Keaney, about keloids?
Yeah, so I think this makes sense as a fantastic option, especially for kind of rapidly growing keloids in sensitive locations that are pruritic, itchy, symptomatic. I think I would combine this with traditional intralesional treatments. I prefer intralesional uh, fluorouracil and triamcinolone combination to minimize hypopigmentation and telangiectasias. So that's my preferred injection. I think the challenge with this class is just getting approval and getting access to drug, given the cost of some JAKs, particularly if you're thinking about oral JAKs versus topical. Ideally, topical JAKs may be more accessible, but this was a oral production, which I think is a better way to deliver drug to a keloid where you're probably going to have a hard time penetrating with topical. So that would be my only kind of concern is access.
Very true, very true. Okay, second article, Histological Changes After Chemical Peeling, with first author Kanthi Balmareddy and senior author Kachu Lee. This was a histology review of 30 studies covering 509 patients on histological changes after chemical peeling. Superficial peels produce mild epidermal thickening with TCA uniquely decreasing melanin, melanosomes, and Langerhans cells. Dermal changes were limited and faded in about 3 to 6 months. Medium depth peels such as the Brody, Monhype, Coleman, and TCA over 35% and 88% phenol showed consistent epidermal and Gren zone thickening with increased dermal thickness, collagen, and glycoaminoglycans. Deep phenol croton oil produced the most durable effects, evenly distributed melanocytes, regenerated collagen, and elastin fibers that persisted up to 20 years. A striking comparative point by Stegman found that the Gren zone's thickening after a 60% TCA peel approached that of a deep chemical peel, so properly performed medium depth peels may offer similar results to deep peels in some indications. Any insights on chemical peels? Do you do any in your office?
So we just do, I'm biased. I'm kind of a laser device guy. So we tend to use our devices for kind of the medium and deep injuries that these peels shows. But I think it really highlights, which maybe the chemical peel literature had been lacking, is, the names of these peels, superficial, medium, depth, really highlights the histological changes that they can create, and they can create them, just as well. I think as energy-based devices. So even though I use a lot of energy-based devices, doesn't mean I think they're better. I think the challenge, what I've always thought is the challenge with chemical peels, there's definitely a nuance way to deliver it. You're applying it all over the skin. If you concentrate, especially if you move into those medium to deeper peels, I think the window of safety in learning hands is narrower than devices. And so that's why the devices tend to be very predictable, reliable. Whereas, yes, in the right hands, you can get predictable, reliable results for those medium, deeper peels, but it's just it's a little bit more of a challenge.
Definitely, definitely. All right, our next article is Dapsone 7.5% gel compared to TCA 20% for peels for acne, with first author Dalia Italia and senior author Aya Badran. This was a split-phase study of 30 patients with mild to moderate acne vulgaris comparing topical 7.5% Dapsone gel nightly to 20% TCA peels every 2 weeks over 3 months. Both interventions significantly reduced the global acne grading scores, with Dapsone from 12.1 to 6 and TCA from 12.0 to 6.4, with no significant difference between them. Dapsone produced a 50% relative improvement versus TCA at 46%. Good to moderate improvement was achieved in about 70% of patients on each side. Dapsone was most notably more effective on inflammatory lesions with a 63% reduction compared to 48% on TCA. Both were well tolerated, but recurrence at 1 month with TCA was about 13%. Do you use either one? Well, we talked a little bit about peels already, but what are your thoughts on the topical agents versus peels for acne?
Yeah, of course, with acne, it's the mainstay of any dermatology practice. So we use topicals. Topical Dapsone is something we've used definitely in the past. Um, you know, Chemical peels are always an option. They're typically out of pocket. I haven't really been able to get coverage for acne. So I just think this shows, you can get similar results with chemical peels with acne as you can with a kind of a topical product. It doesn't mean this replaces one or the other. I would think it's more there are acne patients who are impatient and want to speed this up and add things. So this is another tool in your armamentarium that you could potentially add to a kind of a topical regimen that patients want to speed up and maybe I know it's great that they compared it, but it'll be interesting, if they had a follow-up study where they combined and see if you can kind of speed up acne resolution. I think that would be appealing. But yeah, we offer this. There's a lot of patients who don't want to take orals who are very limited in what they want to do. So chemical peels are kind of like a fourth line therapy for us.
Agreed, agreed. It doesn't have to be an either or, it can be in combination. Okay, shifting gears a little bit here, we are going to talk about congenital malalignment of the great toe, spontaneous regression rate, and limiting factors for surgical outcomes, with first author Olivia Mathot and senior author Bertrand Richard. So this was a study that was the largest series to date on congenital malalignment of the great toe. They had 60 patients, 94 nails, and they were followed over 11 years. They developed a novel severity score based on 6 clinical signs and compared the wait and see versus surgical correction with the rotational flap. In the wait and see group, patients reported subjective improvement in 83% of cases, but the objective expert photo demonstrated that there was no true change. Surgery significantly improved all severity score components regardless of age and baseline severity. Most surgeries were performed between the ages of 4 and 5, and successful outcomes were seen well into the 20s. Complications included post-op infection, lateral ingrowing, and late relapse. The traditional operate before age 5 dogma was not supported by this data. So, Dr. Keaney, any thoughts on congenital malalignment of the great toe?
Yeah, I mean, this is not in my wheelhouse. It's very interesting. I mean, my takeaway from reading this is, if you don't do anything, patients reported satisfaction at 83%. So there's 17% of patients who are unsatisfied by leaving alone. I think this offers surgery as a potential option, but I don't think it replaces watching because, if you look at some of the complications, 18% infection, 12% lateral ingrowing, where only 17% of patients were unhappy if they didn't do anything. So, I think this, it's one of those, if you find patients, you watch will wait, the 17% of patients do not experience subjective improvement. This shows surgery can be very helpful even beyond age 5. So my cursory reading would be like, watch and wait. If you don't get that subjective improvement, surgery is an option, and it doesn't have to be when they're really, really young.
Yeah, that's great insight on it. Okay, moving on to the next one. Ergonomics and hair transplantation. Can technology prevent surgeons from shortening their careers? By first author Nay Arancibia and Perez and senior author Maria Guerrero Roldán. This communication addresses the MSK injury burden among hair transplantation surgeons. Up to 78.5% report work-related MSK pain driven by static postures and repetitive fine motor movement during the 5 to 10-hour procedure. The authors propose combining upper body exoskeleton that supports the arms in a floating position with ergonomic surgical loops offering a 30 to 45 centimeter focal distance in integrated lighting. The two technologies must be paired as the short focal loops are incompatible with the distance that an exoskeleton requires. The authors call for a dedicated study to help validate the ergonomic effectiveness and adaptability to this. So they had a great image in the manuscript showing the exoskeleton that one of the physicians were using. Any thoughts on this?
Yeah, I mean, I think this is a very big issue for surgeons, not only hair transplant surgeons, is, the doing these repetitive tasks, being on your feet, static. So I think this is a big push in the surgery field, and I think dermatologic surgeons should consider it. I do hair transplants. I don't do them all day, every day, but I can easily see if this was something you're doing, all day, every day, how this musculoskeletal issues would be a problem over time. So I applaud, particularly the manufacturer of the exoskeleton. I've seen those before. Surgical colleagues, not in other subspecialties, have used them, and I've talked to them about it. So I think this is a great option. I think, figuring out for each surgery, there might be kind of tweaks to the exoskeleton. So it's not like one surgeon fits all. And depending on the needs of each particular surgeon finding an exoskeleton, it's one step closer to replacing us with AI robots to do surgery.
Mhm.
No.
That I did actually think about that too. And I was like, it's a cool idea.
The exoskeleton would control us and not us not to control the exoskeleton. No, I'm just kidding. But I think this is important stuff.
Definitely. Okay, our next article, high frequency electrocautery and PDT therapy for porokeratosis tachytropia, with first author Leon Zhang and senior author Leon Chong. This was a case that presented a 38-year-old male that had refractory perianal porokeratosis tachytropia. This is a rare variant that has now failed topical corticosteroids, topical retinoids, and oral therapy for over 30 years. They treated him with a high-frequency electrocautery at 20 joules under IV anesthesia to create superficial erosions, which was then followed by PDT using 10% 5-ALA cream at a 635 nanometer red light at 120 joules for 20 minutes. The regimen was then repeated weekly for additional sessions. At 12 months, the lesions were flatter and smoother, and pruritus was markedly reduced with some hypopigmentation, mild scarring. The important clinical caveat here is that this carries a 7 to 12% risk of malignant transformation risk, so long-term surveillance is essential. So Dr. Keaney, this is not something I have seen yet in my career yet. Is this something that you have seen?
No, I haven't, but I know of it, and I think it's important to have this option because given the location and the potential for malignant transformation, it's something that needs to be addressed. And often when you think about that, and people, sometimes describe this as like a pre-malignant lesion, you sometimes worry about doing surgery, and surgery in those locations for these large lesions, would be very debilitating to it. So to have evidence of a potential non-surgical option, which superficial destruction with electrodesiccation and then PDT getting great results, I think you could, number one, prevent something from becoming malignant and save functional, preserve functional benefits in a challenging location, because these lesions usually develop in the perianal area.
Yeah, yeah, definitely. And seems like a little bit like a long recovery, but worth it to reduce the risk of
Yeah.
cancer as well as the pruritus in the area. Great. Our next article, subcutaneous calcifications after the use of synthetic deoxycholic acid injections for fat reduction in the knees, with first author Nicole Tan and senior author Mitch Goldman. This was a case report of a 42-year-old woman, Fitz 2, that received 6 off-label treatments of synthetic deoxycholic acid to the bilateral medial knees for excess adipose. She presented more than 3 years after her final injection with multiple firm, freely mobile subcutaneous nodules at each injection site. Ultrasound revealed a hyperechoic foci with posterior acoustic shadowing measuring about 5 to 8 millimeters, consistent with the subcutaneous calcification. She underwent 4 sessions of acoustic shockwave therapy, reducing nodule size by nearly 50%, with the largest nodule shrinking from 8 to 3.2 millimeters. Her knee circumference also decreased by a centimeter. So this was both a cautionary tale and a management pearl, and the FDA has recently issued warnings about off-label use for fat-dissolving agents. Dr. Keaney, do you use this product in this location? And if so, have you seen similar complications?
So I've used this product fairly regularly. I mean, less so about, especially when it first came out, it's a decade ago, um, deoxycholic acid. So I've used it in this location. Sometimes when I'm using it off label in unintended areas, I tend to want to make sure that this product's being delivered into the fat layer. So I will often tend to use a cannula, even though the on-label indications it's injected with a needle, but with the needle, you can sometimes go too deep, too superficial. I'm not sure if it will play a role in this. These are subcutaneous calcifications, maybe calcifications of the adipocytes. Um, I sometimes also worry about, there are kind of non-FDA approved formulations of these products, deoxycholic acid, that compounding pharmacies will make, and I wonder if those potentially have higher risk. So I would err caution of doing anything off-label, but use a branded product, make sure you're in the fat. But this gives evidence that potentially this is a rare complication, no matter any location, and using uh, the acoustic shock wave therapy could be an option for treatment. It does occur.
Definitely, definitely. Okay, next one. Hyperpigmentation after melanocyte keratinocyte transplantation procedure in a patient with stable vitiligo, with first author Rebecca Quinones and senior author Elfafat Hamzavi. This was a report of a 57-year-old Fitzpatrick 4 woman with a stable segmental vitiligo and a history of melasma who underwent a melanocyte keratinocyte transplantation to the left malar cheek. By day 18, she developed perilesional hyperpigmentation that persisted at 3 months, well beyond the expected resolution. A multimodal regimen was started with oral tranexamic acid, 325 milligrams BID, tretinoin 0.05% every other night, and oral polypodium leukotomos, 240 milligrams daily with tinted sunscreen. By 5 months post-procedure, her hyperpigmentation had markedly improved. Hydroquinone was not used due to avoid the theoretical risk of vitiligo reactivation. The authors emphasize that PIH after this transplantation is uncommon, but may be more likely in patients with higher skin phototype and concurrent pigmentary conditions like melasma. So I wish we had an article about melasma because I'd love to pick your brain, on your melasma management and everything, but any thoughts on this article?
Yeah, I mean, this patient had a history of melasma. The transfer was done on the cheek, which is an area prone to that, and it sounded like the pigmentation was perilesional, so not actually where the transplant was occurred. So it could be PIH, it could be melasma reactivation. I think it does not preclude, the use of this of using melanocyte keratinocyte transplantation. It's just something maybe proactively someone in a history of melasma, rather than wait to see if it develops, you could proactively put some on potentially tranexamic acid, polypodium leukotomos, like proactively to kind of prevent rather than wait to see if it occurs. Uh, but yeah, melasma is tricky. Sometimes I think prevention is sometimes, it's just as important as correcting once it develops. But this just shows a unique example of this occurring. But it responded well, so it's great.
Wonderful. Okay, next article. Picosecond lasers and hypopigmentation, translating histological insight into clinical caution, with first author Shi-Zan Hong and senior author David Lim. This letter was a response to the histological review of laser and energy-based devices for pigmentary disorders. The authors reported a real-world case series where 0.38% of 796 patients, predominantly fits 3 to 4, developed a persistent, well-demarcated focal hypopigmentation after using the picosecond for the treatment of melasma. Hypopigmentation persisted at 6 months follow-up. Their proposed mechanism was preserved melanocytic numbers, but reduced melanosome content, dendritic retraction, and impaired melanosome transfer. The authors challenged the perception that picosecond devices are uniformly safe in melasma and caution against cumulative subthreshold injury from repeating passes and pulse stacking. Do you have a Pico device or any experience with Pico in your practice?
I do. So I do have a picosecond device. We have a 532, 785, and 1064 device. We use it for melasma. Melasma, as we mentioned in the previous case, melasma is, often a combination therapy depending with a prescription topicals, oral therapies, as well as lasers. We we use Pico devices. We also use 1927 nanometer uh, light fractional resurfacing.
Mhm.
Sometimes it's first line therapy. The Pico can be unpredictable. Not necessarily. I find it traditionally safe. I have not seen much hypopigmentation, but sometimes it can be underwhelmed because you have to be low settings. You don't want to hit the melanin too hard. It is, those wavelengths, particularly if you're in the 785 range, are somewhat more pigment specific. So you have to be cautious. So I find that the lasers like the 1927, not directly targeting pigment, but kind of turning over the skin at the area of pigment deposition are often first line therapy. And then I transition to Pico, is how we kind of use it in our practice.
Yeah, I couldn't agree more. I also use a Pico device and I can find it a little bit unpredictable, especially when treating melasma, which can be also unpredictable. So great. Okay, our last article, this is a comparison of pain perception between needle and cannula subdermal injections for PDLLA, a randomized double-blind split injection study with first author Q Yo Yi and senior author Zhizhong Kim. This was done out of Seoul, where they conducted a randomized double-blinded split-phase study of 37 patients comparing pain perception for subdermal injections delivered by needle or cannula. Each patient received 0.2 mLs on each cheek, one side with a 30-gauge needle at 5 injection points, and the other side with a 27-gauge blunt-tip cannula through a single entry point with a small amount of intradermal lidocaine pre-numbing. Patients were blinded to which side received which technique. The mean visual analog pain scale scores were 5.87 for the needle side and 2.83 for the cannula side, a roughly 50% reduction in pain, and it was statistically significant. There was no differences between sex, but older patients did tend to have lower pain scores on both sides, which the authors attributed to age-related demyelination of the sensory fibers. So the main takeaway here is that for biostimulators, at least delivered over broader areas, cannula may provide more patient comfort. So, Dr. Keaney, which one do you use, or does it depend on the location?
Yeah, I mean, I would say I'm a big cannula user. I still use needles in certain instances, as I mentioned previously, acne scars, sometimes lips. That helps me shape. I do agree with this data that my patients find cannulas more comfortable. There's less needle entry points for the cannula access. What I do find, which they did not study in cannula use, I think the rate of fainting or vasovagal is higher in cannulas because there's this tactile, you're kind of pushing through tissue planes and you feel this kind of pressure changes, which is not painful, but disconcerting sometimes. So I really warn my patients on it, but I do find that fainting is a little bit more common. Uh, so that's one thing I counsel my, you know, other providers to be aware of. Just have a fainting protocol. It happens with needles, but I find it happens more with canines. But canines are safer, but also, more comfortable. I do find they, and literature's backed this up, that they are safer in terms of vascular occlusion events. So, that's another big reason to use them.
Definitely. Awesome. Well, thank you so much, Dr. Keaney, for sharing all your pearls today. Many important practical takeaways. Thank you for our listeners for tuning in. For a deeper dive in the other spotlight articles, please check out our companion episode on the same platform or visit asds.net/DermSurgery-Digest, and we will see you guys back next month.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.